Geriatric Syndrome. The topic I chose was syncope. Syncope is one of the high utilization costs for Medicare. On hospital admissions for syncope, 80% are over the age of 65. With the new payer system in the United States, there is increased pressure to improve the value of health care, defined as health outcomes per dollar spent. My patient for this is a 77-year-old female, married for 61 years. She come to the office because she had 2 spells where she gets dizzy and almost faints. She has no known drug allergies. She is intolerant to aspirin due to GI bleeds. She is currently on hypertension medication, hyperlipidemia medication, along with diabetes medication. She also takes over-the-counter supplements and Tylenol PM as needed. My patient is also up to date on her immunizations. She is involved in her health maintenance and disease prevention. She walks when the weather is nice. She tries to follow a DASH diet. And she also makes sure she protects herself against skin cancer when she's outside gardening. Her past medical history includes hypertension, type 2 diabetes, hyperlipidemia, vertigo. She's had a few hospitalizations with a couple of surgeries. She had a cholecystectomy, hernia repair, appendectomy, tubal ligation, a colonoscopy in 14, and also she had her children. Patients presenting with syncope may show signs of fatigue, dehydration, pain, fear, alcohol consumption, warm environments, or loss of consciousness. It is very important to get a very detailed history of the symptoms. Is the syncope at rest, when standing, sitting, lying, changing positions, with exertion, with voiding? Some of the questions that are imperative to ask: was the loss of consciousness complete? Was loss of consciousness with rapid onset and short duration? Was recovery spontane, complete, and without sequelae? Was posterior tone lost? And was the event witnessed? Again, these are common complaints with syncope: blurred or faded vision, paresthesia, diaphoresis, weakness, vertigo. On this patient's review of systems, she did notice some numbness and tingling when she felt dizzy and had experienced these spells. She did not have any history of seizures, TIAs, head trauma, MS, Alzheimer's, no bowel or bladder incontinence, no history of sleep apnea, no history of loss of consciousness. She did experience dizziness, changing positions from sitting to standing, and she does have a history of vertigo. As you see from the slide, her vital signs were good, no concerns. On this patient's physical exam, there was no signs of any abnormalities. Her motor and coordination was good. Patient's cranial nerves, cognition, and affect were all normal. She actually scored a 30 on her mini mental exam. No deficits noted. For her screening exam, I used the CATS ADLs and the Tenetti Gait and Balance, which she passed beautifully with a score of 28 on the Tenetti and 6 on the CATS. With any patient presenting with syncope, an EKG should be obtained. which hers was normal. I also ordered a transthoracic echocardiography to evaluate structural heart disease, which was normal. Her labs were all normal, which included a blood glucose, hemoglobin A1C, that was 5.6, well controlled, a CMP, anemia profile B, which were all normal. She also had a troponin level, which was normal. For my plan, I'm going to have the patient keep a blood pressure monitor log for 2 weeks, document any syncope episodes, document what she is doing at the time of the episodes, and if they are witnessed. Some of my differential diagnoses will be cardiac arrhythmias, structural cardiopulmonary disease, a MI, or acute hypoglycemia. I ruled out cardiac arrhythmias and structural cardiopulmonary disease because of the normal EKG and echocardiogram. I ruled out an MI because her EKG was normal, as well as her troponins. The acute hypoglycemia, the patient's blood glucose was normal at the time of the visit, and her hemoglobin A1C was 5.6. My final diagnosis is reflex syncope. The history, physical exams, labs, and EKG were all non-diagnostic in this patient. So a normal EKG findings is a good sign. The absence of heart disease excludes a cardiac cause of syncope in 97% of patients. If the patient continues to have these episodes, I will order a tilt table test at her follow-up. Challenges and barriers are trying to identify any associated symptoms, educating the patient on the etiology of the syncope, and trying to find preventative measures to avoid reoccurrence, and also educating her on the importance of hydration status. For the community resources, I would refer my patient to the local senior citizen center, where she can get involved in some physical fitness, activities, and other services. I would also refer her to the healthyaging.org website. The health team that I would get involved with this patient would be possibly physical therapy if these episodes keep occurring, a mental health consult if these episodes are occurring and lasting longer than 5 minutes at a time. In the discussion, were health behaviors identified in this case? Yes, I think so. This patient was very active, pretty much physically fit for a 77-year-old and very independent. Some of her social determinants of health is her age at 77, also her fixed income. The socio-economical issues and cultural issues that may affect my topic was if she couldn't afford food, this would impact the diagnosis, and if she didn't have a safe environment at home, would also affect this topic. As far as the legal or ethical issues, if the provider thought the patient's home situation was dangerous or unsafe, as health providers, we're mandatory reporters, so we would have to report this to the Adult Protective Services. I learned the workup for syncope. I also learned how important it is to get the history. You need to get as much information as you can before the physical exam even starts. You just have to keep questioning and digging until you can get all the information from the patient.